let's get started. I have a couple review questions, and depending on how recently you watched the lecture, or if you watched it, or if you paid attention, these may make sense or may not at all, but we'll talk through them. So this is kind of how I'd ask a test question. I try and throw out a few of these examples periodically during all my modules. So here's some questions and examples. Which of the following combinations would be reasonable to start if your goal is to provide broad spectrum coverage to include possibly resistant gram-positive, gram-negative, and anaerobic bacteria? So the reason I'd ask a question like this is because it really applies to a lot of different types of infections you would treat in different parts of the body. So it's a nice question to capture sort of the essence of broad spectrum coverage. So what do we want to do when we want to provide broad spectrum coverage? What are some of those definitions? Or does anybody have an idea? Do you know the answer? I heard C and I heard B. Anybody want to argue one or the other? Ceftriaxone's pretty broad spectrum. What's Zosyn? Is that more broad spectrum or less than ceftriaxone? Do you know what the magical bacteria that Zosyn covers that's kind of our benchmark? Pseudomonas. So when you're talking about broad spectrum, you always want to cover, I always think of three things. So MRSA, Pseudomonas, and anaerobic coverage. Now, of course, you want your general gram-positives and gram-negatives covered, right? But we don't really worry about that because you assume if you cover Pseudomonas with something, unless I tell you otherwise, it's probably going to have pretty good general coverage as well. Yeah.
Can you repeat those three things?
Yeah, so MRSA, Pseudomonas, and anaerobic coverage. That's going to cover pretty much everything in most major areas of the body. Now, some things we'll talk about today, there's nuances. Like you don't want to use Zosyn, for example, in a central nervous system infection because it doesn't penetrate the blood-brain barrier. You'd want to use a cephalosporin, or something else. But there's little caveats here and there. But for the most part, that's a good broad-spectrum combination to start with. So yeah, B is the correct answer. Just to go through the incorrect ones, A is not correct. Why? Anybody have an idea? Why A isn't correct? Yeah, so ceftazolin's a first-generation cephalosporin that really only covers MSSA and some other general gram-positives, but yeah, no MRSA coverage. Primaxin's super broad spectrum, so that's good for the anaerobic and gram-negative and Pseudomonas side. You're just missing MRSA.
So when we're learning these, do you want to know the generic name and the brand name?
I want you to know, so per your program, I have to test only on generic names. I'm not allowed to put the brand names on the exam. I do give you brand names because people use them in real life all the time, and that's probably what you're going to call them. So I'll kind of go back and forth, but I give you both, and you'll see them as as generic names on the exam.
Okay.
Yes.
So in your practice, is there one way that's more effective than others?
Yeah, it depends. I like, especially for the combination products, like saying the brand names is just easy to say Zosyn or to type in Zosyn to a computer instead of saying piperacillin, tazobactam. But yeah, it depends on the drug. It depends on sometimes how long it's been around on the market too. And again, yeah, provider-specific preference. Some people just like to use brand names, others don't. Yeah, it's a toss-up. So C, we talked about incorrect. Ceftriaxone is a great drug. It covers a lot of things. It just doesn't cover Pseudomonas, and its anaerobic coverage is kind of hit or miss. And then linezolid and azithromycin. So this azithromycin is just simply wrong. It's not going to be really a part of broad spectrum treatment unless you're talking about pneumonia, which we'll talk about in a few slides here. And linezolid's okay for MRSA, but it's not a first-line option. Vanco is always your first choice for any MRSA infection. Linezolid is a good second choice, though, for a lot of infections, if your patient's allergic to Vanco or something like that. Okay, next. Which of the following medications would not be appropriate for an infection caused by Pseudomonas? See, yeah, I just told you that. Paying attention? Okay, 3. Based on the following patient allergy information, which of the following antibiotics would be least likely to cause an adverse reaction? So this patient's reporting hives to penicillin, a rash to cephalosporins, and fluoroquinolones tendon pain. So we've got 4 choices: Augmentin, which is amoxicillin clavulanate, cephalexin, Keflex, Cipro, and doxycycline. And remember, we're talking about allergies or an adverse reaction, so think about that. This is what I like to call the easy way out. Doxy, yeah. So Doxy doesn't have isn't part of any of these classes, right? This is a nice person. If you get a person like this and you're like, I really just don't want to test the waters at all, and Doxy will work well for it. Let's just go down the path of least resistance. If that's not an appropriate treatment choice, then of course you might want to look into some of these intolerances or allergies a little bit further. But at the same time, it's nice to have options out there that you know are not going to cause some kind of an issue, or at least historically haven't had an issue with the patient. Not yet anyway, right? Some patients, no matter what you give them, they will have an issue with it. So you can't win always. All right, so those are some basic kind of test type questions. Again, this exam is mostly focused on antibiotics. There'll be a smattering of other anti-infective type stuff in there too. But my questions will be something like that, where they're more basic and just talking sort of about the drugs as a whole, or focusing on a mechanism of action or a side effect profile of a medication or a class. And then I'll have more complicated questions, which are more case-based. So I'll give you a case, a patient scenario, and I'll ask you a treatment strategy off of that. It's always multiple choice, and I always try not to duplicate or put things in there that are too confusing, but obviously I don't want to make it too easy either. So anyway, there is usually one best answer. Sometimes there might be an answer that's slightly correct, but usually one that's preferred, and sometimes that may be based on guidelines or recommendations that I'll go over too. Again, I try not to be too complicated, but it is a lot of information, and there's a lot of antibiotics. Okay, so some things I like to remember when considering treatment. These are sort of the guidelines for how to think about infectious diseases. So you have the source of infection, and what are the most common pathogens for that particular source of infection? Did the patient recently use an antibiotic, and did they fail it? This is a really common mistake I see, especially in urgent care, where people come in and they failed levofloxacin or ciprofloxacin or something, and they prescribe another fluoroquinolone. It's probably a bad idea. Usually it's class resistance in those cases. So knowing those nuances there. Previous exposure, have they had this bacterial infection in the past, and did they respond well to certain treatment? Previous culture data, this is really key. Now, if culture data goes back like 3 years, their urine culture from 3 years ago probably isn't super relevant to what's going on today, but if they had one 3 weeks ago, that certainly is relevant. So use some clinical judgment there, but for the most part, I like to think of a cutoff like within a year of having a culture being sort of within the realm of we still think about that as important. Tissue penetration, certain drugs just don't get to certain areas of the body. Like I just said, Zosyn doesn't really cross the blood-brain barrier. So you have to consider that in some cases. Now, in most cases, we don't worry too much about that. But the specific ones I like to think about would be osteomyelitis. Getting into the bone is a little bit difficult. And the central nervous system would be the two that kind of stick in my head. Allergies. Don't forget about your patient's allergies. It's probably going to be one of the biggest phone calls you get back from a pharmacist if you prescribe, whether it's inpatient or outpatient, is, hey, this patient's reporting a penicillin allergy in my system. You prescribe them cephalexin. Is that okay? So the cross tolerance I talked about in the previous lecture, but just know that that's going to be something that happens a lot. If there isn't documentation in the chart that the patient tolerated a cephalosporin in the past, and you're like, well, it's a low percentage of cross-reactivity, I think it was a mild reaction, I'm okay doing it, that's still something that if somebody doesn't have that information, they might call you on. So just know that that's something that comes up all the time. Infection parameters, so of course the basics for your physical exam, which I'm not going to go over, you do that in other classes, but your temperature, white blood cell count, following the culture data is really important. And then of course organ function to see how systemic and advanced is this infection. All right, so I'm going to walk through a review of systems here, basically going through the body and talking about different common infections I see. I worked emergency department for 5 years, so I've seen pretty much every type of infection imaginable. I work at a quaternary care facility, so we see really sick people, and it's a lot of interesting stuff. But anyway, I'll kind of put the highlights here through this lecture. So cellulitis, basic skin and soft tissue infection, can affect multiple areas of the body. Usually some source precipitated it, so either like a puncture wound or a scrape or something like that. Treatment, we're going to cover basic skin pathogens. Really, that's all you should need to do in most patients. So empirically, we're going to look at gram-positive coverage. So Staph aureus and Strep pyogenes are the two most common skin pathogens. All of us have this on our skin at any given time. It's just we don't get infected by it because most of us, if we have a cut, the immune system is going to ward off any type of opportunistic pathogen there. If it is deep enough, though, it can seed, and then you can end up with an infection there. That's why for surgery we prophylax against that, because you're cutting into the skin. The skin has these pathogens on it, possible pathogens, I should say. Cephalexin cefazolins are first generation cephalosporin, and it's kind of the gold standard for any type of basic skin and soft tissue infection. You don't need to cover empirically for MRSA unless the patient meets some other criteria. So specifically, purulent drainage is sort of the hallmark for if you want to cover MRSA right off the bat or not, without a culture, of course. Recent exposure is another thing. Did they have a family member with MRSA? I'm trying to think of another example of that, but do they work in healthcare, maybe something like that, or do they injure themselves at work? PO options, mostly for community-acquired cases. So if somebody has MRSA from a community-acquired case of cellulitis, we can usually stick to oral therapy. We usually don't have to admit those patients for IV antibiotics. And those are the 4 drugs there that would cover MRSA. And then you have IV options as well, so doxy, clinda, vanco, linezolid. Again, for the vast majority of patients, we're going to go with vancomycin right off the bat to cover cellulitis if we think MRSA is the pathogen. Combination therapy, MRSA agent plus. Sometimes what I see people do is prescribe like Bactrim plus cephalexin, which might not be all that make a whole lot of sense. But the thing is that Bactrim doesn't really cover strep all that well. It covers some other species of strep actually, but it doesn't cover strep pyogenes very well. It does cover the Staph aureus, either MSSA or MRSA. It's really good for Staph aureus. So if somebody's suspecting MRSA, but we might want to narrow therapy in the future or cover strep just as a background, sometimes they'll do both of those. I'm not necessarily recommending that. I think the problem with wound cultures is if you get a cellulitis patient and you culture whatever's coming out of that, it's probably going to grow staph. I don't think I've ever seen one grow strep. Well, it's pretty rare. And I'm not sure if strep infections, A, aren't purulent, right, based on our information here, and you don't really have a lot of fluid to culture, for one thing. 2, I think strep infections tend to present a little bit differently where, again, if you swab the skin or something, you're probably just going to pick up staph that's on the skin. And I don't think it's as easy to culture the strep off the skin. So honestly, out of all the wound cultures I've done in my life, which would probably number close to 1,000, if not more, staph is always almost the pathogen you're going to see. Or it's not going to grow anything at all, or it's going to grow just a bunch of stuff that looks kind of junky like it's just on the skin. So anyway, my point is that strep is not something you commonly culture, commonly see in your follow-up care. So that's why some people might want to cover it empirically, even if you're concerned about MRSA. Now, if you do culture it and you get MRSA back, you can probably safely DC the strep agent. So let's say you wanted to cover all your bases and prescribe a patient Bactrim plus cephalexin, and then it comes back growing MRSA, just get rid of the Cafalex or cephalexin. You don't need it at that point. But it is something that's done occasionally. Again, it's provider specific. I have some providers that like to do that, some that don't. Kind of comes in and out of favor depending on who was trained where. Not really a right or wrong answer to that. It is appropriate if you feel the need to. But a lot of people just roll the dice and give them Bactrim as a monotherapy, I would say, if they're suspecting MRSA. IND, so IND is going to be by far and away the best therapy here. There's actually some evidence out there that says, a lot of evidence says an IND by itself is probably, if you do it correctly, you don't really need antibiotics. At that point, you're almost prophylaxing against a regrowth of the bacteria because you should be cleaning out any type of bacteria from that abscess. And in that case, we really still do prophylact. And so if it's going to be a purulent liquid, generally you're going to give them Bactrim just to make sure, probably MRSA, don't want it to regrow or refill up with gunk again. So make sure they're getting good wound care and things like that, of course, too. But that's as important, if not more important, than antibiotics. I just want to point that out. Some other considerations: puncture wounds, animal bites, human bites, all kinds of things like this come up. And if somebody can injure themselves in a certain way, you will see it in your career, especially if you work in urgent care or EM. Even family practice, you probably will see some odd stuff come through. Puncture wounds, so you want to consider the location of the wound. Where is it and what tissue might have been damaged with it? Obviously, that could change your way. What were they punctured with? Was it a rusty nail through the bottom of a dirty shoe? Or was it a clean instrument during a sterile procedure? Of course, that's going to change. Water is notorious for Pseudomonas. So if you do get somebody, and water also has like Citrobacter and some other odd gram negatives that you don't really see other places. So if you do get water injuries, know that you might want to consider more broad spectrum therapy to start. So I like for water injuries like ciprofloxacin right off the bat, even though it's kind of an odd thing that we didn't talk about on this slide. It does make sense if you have somebody with a significant cellulitis and they were, cut their foot on a rock in a lake in Minnesota. That's probably going to have something in it outside of standard skin pathogens that we normally see. Not always, but certainly worth thinking about. Animal bite wounds, or animal bite/wounds. So it's always a trivia question. What animal causes more infectious related bites, dog bites or cat bites?
Yes.
Okay, I feel like somebody tells you this before I talk to you, or maybe you guys just don't like cats. But so cats have long, sharp, pointy teeth that penetrate deep into tissue and seed bacteria inside the tissue, whereas dogs have really strong jaws, but they more do surface damage if they're going to bite somebody. Certainly you can get both. You can have a cat bite that's not infected, but I think like statistically almost over 90% of cat bites end up with a cellulitic profile if they aren't treated, and about like 5-10% of dog bites will actually get bacterial infections, so it's quite different actually if you look at the stats. We usually treat augmentin, or we treat cat bites or dog bites with augmentin. And in fact, most animal bites are treated with augmentin. Things that grow in the mouth tend to have anaerobic components to them, and a bacteria called Pasteurella or Bartonella are a couple things that animals carry that are covered by this specific bacteria, or a bit by augmentin quite well. So that's our preferred choice. You can give them IV unison too. Remember, that's kind of our IV equivalent of augmentin. If you want to give them something IV to get them started, that would be appropriate as well. But oral augmentin is usually appropriate. That applies to human bites too. If somebody gets bit by a person, more than likely that person maybe punched somebody in the face and got a laceration on their fist due to a tooth, and that could be potentially something you treat with augmentin over maybe just like a basic Keflex. So just some little differences and some pretty common things you see. Oh, the Sanford Guide, I'll just put in a plug there. They have this cool table that shows all kinds of different animals you could possibly get bitten by and how to treat them. So in case you want to nerd out a little bit, there's that for you. Diabetic foot ulcers are really deep, really difficult to treat, and usually due to poor circulation and poor diabetic care overall. So these people don't have good feeling to their extremities. And what happens is they get an ulceration that just grows and grows and grows. There's not a lot you can try. You can try to do this, but ultimately wound care and specialty care like debriding the area, hyperbaric oxygen therapy will be the things that are going to be probably more effective than antibiotics, just because you need a blood supply to get to that site in order to be able to do something. And if you can't get blood there, you can't get the drugs there. So we can try. Usually what we're going to do with a diabetic foot ulcer is just go really broad spectrum, because if you swab this, you're going to grow everything under the sun, and that includes MRSA, probably advanced gram-negative species like Pseudomonas, and also anaerobic bacteria for sure. So vancomycin, great example of what we do. Alternates would be like vanco, cefepime, metronidazole would be a good choice. Vanco, imipenem, Primaxin, brand name would be another good choice. So those types of broad spectrum therapy is what you'd try. Bone involvement, which leads you further down the road to osteomyelitis. Osteomyelitis is pretty similar to skin and soft tissue infections, but it's much more involved. Usually we treat IV right away. You can maybe switch to PO for osteo, but again, this is one of the areas where it's hard to get drugs to the site you need it to, and PO might just not get the levels you need high enough in the blood to be able to get into the bone. So IV is preferred in a lot of cases, at least initially. Usually with osteo, you're looking at weeks of therapy. So you want to continue therapy until the debrided bone is covered with new tissue. This can take about 4 to 6 weeks. It really depends on whether or not the bone was removed. If they amputated some part of somebody's body to treat the infection, that's going to require a lot less therapy, right? Because your bone, the infected part of the bone's gone. If they didn't amputate, or they can't amputate that particular part, then you're looking at like the 4 to 6 week duration. We almost always empirically cover for MRSA until we can rule out anything else. And then bone penetration, again, usually I'm thinking these agents are pretty good for penetrating to the bone tissue. So we have a lot of options, fluoroquinolones, clindamycin, cephalosporins, your MRSA agents, potentially vanco, with daptomycin and linezolid being your 2 alternatives that you could consider. So usually what we start with is vanco plus ceftriaxone, or you could even go a little broader spectrum if you wanted and do like a cefepime. You don't really need to cover anaerobes in an osteomyelitis. It'd be odd to need that, but yeah, I'll leave it at that. And then bone biopsy is sort of the gold standard for figuring out what is actually growing on the bone, and that would be how you'd narrow therapy off of All right, derm stuff. We'll have a whole derm topic discussion next winter. I believe it's in January sometime. And we'll talk more about topical agents and how they all work. Usually they don't have a huge role. They can help with small lacerations or abrasions, prophylaxis while healing type things. We'll discuss acne specifically as a separate module as well. So don't worry about that for this exam. Okay. Any skin structure infections before I move on to ENT? Okay, ENT infections, sinusitis, tonsillitis, otitis media, etc. Usually you're looking at a couple basic organisms. So strep pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis are kind of the three big ones. You could have atypical pathogens too, but that's more getting into community-acquired pneumonia versus ENT, so we'll talk about that in a couple slides here. Rhinosinusitis is mostly viral, and it's basically going to resolve on its own in the majority of patients. However, this is one area of medicine where I don't think we're very good at treating because I think we overprescribe antibiotics a lot to these people. And it's a difficult situation. If somebody comes in and they said, you know, they've had this cold that hasn't gotten better and it's been like 2 weeks, what do? Do you assume it's gotten bacterial at that point? I don't know. It's kind of hard to diagnose that, at least from what I understand. So it's a little bit of your own judgment. I don't think it's wrong to prescribe antibiotics to these people, and you can see that a lot of people will get this if they present to an urgent care or something. They've probably gone long enough with pretty bad symptoms where they want to try something new at this point. So again, if it doesn't resolve on its own, looking maybe at an anti-infective, so looking at something like a basic penicillin type drug like amoxicillin, plus or minus the clavulanate component. Usually people, for adult patients, they usually just give Augmentin. That's pretty common versus just plain amoxicillin. If you had somebody who's pen allergic or won't tolerate the Augmentin for whatever reason, alternate agents, doxycycline, more advanced generation fluoroquinolones like levo or moxifloxacin. Azithromycin by itself might be okay. It covers Haemophilus and Moraxella pretty well, but it has really bad strep pneumo coverage, so you're missing one of those. But for ENT infections, you might be able to get by with it. I don't necessarily recommend it as a first choice. I'd probably use something else. I'd stick with the Augmentin or even just plain amoxicillin over azithro plain, but it might be a choice, especially if somebody has a lot of allergies and you don't have a lot of other options to pick. Yes?
Would you pretty much use the same things for children as you would for adults?
Pretty much, yep. I do a separate pediatrics lecture in the summer, and I go through some of more of the otitis media and basic things. But otitis media for kids and general upper respiratory tract is usually just high dose amoxicillin, and then maybe Augmentin if they fail amoxicillin. Sometimes third generation cephalosporins too. That's sort of the progression you'd go in.
Is that kind of a general rule as we go through this, that whatever we prescribe in the adult would also be for a child?
For the most part, yes. I've got a couple caveats on that, and I'll go through those in more detail during the peds stuff too, because some of it's like you can use this in a 2-month, or can't use this in kids under 2 months. So it's a little bit like neonatal and stuff like that I don't think is super relevant to our discussion right now. But yeah, generally speaking, you can use pretty much any antibiotic in adults as you can in kids. The dosing just changes. And the guidelines are somewhat different on what treatment strategies you use. All right. Tonsillitis, pharyngitis, group A strep, pussier head, strep throat. Anybody want to admit it? Several people, yeah. Really common. So when you have a strep throat test, you do a rapid test. The rapid test has a lot of false negatives, and so they culture the throat automatically, usually, if there's a false negative. Throat cultures can grow one of 3 things. Well, they can grow nothing. They can grow group A strep or group C or G strep. Group C or G are thought to just be normal flora. So if you see a throat culture come back growing group C or G strep, probably you don't need to do anything, especially if the patient's symptoms are resolving. If they're getting worse, you could still consider treating it, but it's a bit of a gray area. We generally don't treat because it's self-resolving in most patients. The reason why we treat group A strep a little bit more aggressively is people can get acute rheumatic fever from it. It's a super tiny percentage. I worked with this really cynical physician who would always say that you're more likely to get anaphylaxis from penicillin than you are to actually get rheumatic fever from group A strep, which he might be right. So anyway, the odds of getting this it's really rare. So, but technically, if you don't treat it, the group A strep does produce a toxin that you could have an immunologic response to in a small amount of patients, which is kind of like an anaphylactic type response. So anyway, The idea is we prevent that from happening, but the better idea is we prevent the spread of group A strep to other kids or adults or whoever has it, which is the better way to look at treating this. So usually you can treat somebody, and after 24 hours of antibiotics, they can go back to school or daycare or whatever. Treatment. So treatment for this is really basic. This is one of the few areas in medicine we still use plain old penicillin. Penicillin, 1.2 million units, IM, 1 dose, and then you could do the oral as well. So occasionally that penicillin IM injection goes on and off shortage. Sometimes we go through months where we can't get it. So it's good to know that there's the oral backup. And if you have a patient that can't tolerate penicillin or has a documented allergy, your backups would be azithromycin or possibly a higher generation cephalosporin to try, depending on how severe the allergy. Azithromycin does cover group A strep quite well. Well, I said it doesn't cover strep pneumo well. So remember, 2 different types of strep. Azithro works pretty well for this one, but not for the strep pneumo. So don't feel bad about using a Z-Pak for a strep infection. That's okay. But when it comes to like other respiratory stuff, be a little bit careful with that one. You may have anaerobic, atypical involvement potentially, depending on how significant the infection is or how deep it is. Like if you're talking about like a tonsillar abscess or something that, of course, that's a little more advanced than what we're talking about here, but certainly something like that something basic could turn into something more severe. So there you could cover with clindamycin, which will cover anaerobic species in the mouth, and then azithromycin for atypicals. This is one of the areas where clinda, I think I mentioned this in the other lecture, but I think of general rule, like clinda kind of for anaerobic stuff like above the respiratory tract, and metronidazole for everything kind of in the GI tract and below. Otitis media, just said this, but usually observation is the first thing you do. So it's 48 to 72 hours for improvement. Still febrile after that 72-hour mark, you can consider treatment. Some parents might not like that idea, so that'll be up to you guys to figure out what you want to do with that. Fortunately, I don't have to worry about that. Same bug, same treatment. Again, basically, this is a kid thing. So like you were saying, amoxicillin high doses for otitis media. And you can use the same backups here as you would for group A strep, like what we just talked about. So azithromycin, 3rd-gen cephalosporins. Topical therapy, you can use eardrops if they have a ruptured tympanic membrane. Usually you're going to use a fluoroquinolone eardrop like Cipro, and I think moxifloxacin comes as an eardrop too, but usually you're going to use Cipro. Conjunctivitis, bacterial versus viral. It's really hard to tell the two apart from what I understand. Again, I'm not a diagnostician. The same bugs. Staph aureus might be more of a concern in adults. So if you have kids, probably not going to worry about staph. Adults, maybe, but it's pink eye is a lot more rare in adults, unless they got it from their kid, and then in case, probably aren't worried about staph. Anyway, topical antibiotics. I don't recommend using ointments. They're super goopy. Maybe unless it's a really small baby, you might be able to get away with that because they can't really seal that well to begin with, and they probably aren't going to notice if you put goop on their eyes. I'll just be honest. Polymyxin trimethoprim drops. So it's kind of an odd antibiotic, but that's one of the most common cheap ways to treat conjunctivitis, and it's a pretty popular way. Otherwise, fluoroquinolone eye drops like Cipro eye drops. Ofloxacin is a common one as well. It's kind of a specific floxacin that's used in ophthalmic preparations. And azithromycin drops exist too. Usually you're going to use a polymyxin trimethoprim first, but some patients, I think when my kid had, my wife took one of my kids in for conjunctivitis last year, they gave us ofloxacin right away. I don't really care. It's just an ophthalmic preparation. It's not getting systemically absorbed. I think the odds of getting resistance or using good stewardship doesn't really apply to this as much as it does other places, but certainly the fluoroquinolones are going to be more broad spectrum than your polymyxin trimethoprim. All right. Questions about ENT before we move on to pulmonary, lower respiratory? All right. Pneumonia. Pneumonia is probably one of the most common things you'll see if you work in emergency medicine, and maybe from a certain perspective, urgent care. It's just a super common presentation that leads to a lot of hospitalization, and it has a lot of background on how people can get pneumonias, and I'm not going to talk about that, but let's talk about the types and what you might see and where we might go with treatment. So you've got 4 major types of pneumonia, the community-acquired being the most common one. You have healthcare-associated pneumonia, which isn't really a real term anymore. They basically kibosh that one, but I still talk about it because I think people use it occasionally. Healthcare-associated pneumonia was a term used for people who just have a lot of healthcare exposure, but not necessarily hospitalization. So maybe they were in a nursing home or are kind of in and out of transitional care facilities or something like that, but not necessarily a hospitalized patient. Hospital acquired is somebody who's been hospitalized for another reason and now has a pneumonia because they're during their hospitalization, possibly due to a normal pathogen, or it could be a hospital acquired pathogen, you don't really know. Ventilator-associated pneumonia is much more severe. That's an ICU patient on a mechanical ventilator who gets a pneumonia because of that. That's usually some pretty nasty pathogen. We cover both hospital and ventilator-associated pneumonia very aggressively with broad-spectrum stuff, so it's a completely different treatment algorithm, which I'll talk about in a second. It's actually a lot more simple than CAP. CAP guidelines aren't necessarily the most straightforward, but we'll go through them here in a second. All right. Okay, so your common CAP pathogens, my Zoolander reference. Yeah, I put all kinds of dumb pictures in my, I think like the further on in the course we get, you'll see I get less and less dumb pictures because I just lost any interest in doing that. But anyway, here you go. So you've got strep pneumo, respiratory viruses, H. influenzae, and then your atypical pathogens. So the atypicals being mycoplasma, chlamydia, pneumonia, and Legionella. All right, so your outpatient setting. Previously healthy person with no antibiotics in the past, you can use azithromycin, just not if you're treating anyone in the United States of America. Some countries around the world might have less than 25% local resistance to strep pneumo, but no place documented in the U.S. has that. And most places in North America and Europe don't have any enough good coverage of azithromycin for strep pneumo that you can use it. So my rule of thumb, and one thing I want to say, and I'll say it a bunch of times, is never treat somebody with CAP with a Z-Pak as monotherapy, no matter how healthy they look. It's a really bad idea. You're missing your most common pathogen, which is strep pneumo. And that patient, if they bounce back into the ER, that's on you. So I've seen this happen dozens of times where people come into the ER because they got prescribed a Z-Pak for CAP, and now we have to treat them with IV antibiotics and admit them to the hospital. I'm not kidding. I'm not trying to be a jerk or anything, but it's just super annoying. It's straight in the guidelines. Don't use it if you're practicing in the United States of America. Okay, so what can you use? Doxycycline is a good alternative for a healthy patient. I like Doxy personally for a number of reasons. It's not the best if you look at its coverage rate for strep pneumo. It's got like a 90-ish percentile coverage rate, which isn't bad, but compared to some of these other ones that are more like 98%. Anyway, Doxy can be used in a lot of patients. I like Doxy in certain people because it doesn't have a lot of drug allergies or First of all, a lot of people aren't allergic to it. Second of all, a lot of people don't have who are on other drug regimens. It doesn't have as many drug interactions. For example, fluoroquinolones are kind of nasty with drug interactions for certain diseases. And also azithromycin, if you're using it in combination with something, is not good for drug interactions. Doxy is a much more benign when it comes to drug interactions. It still has some things wrong with it, but it's better than the other ones. So I like it because it doesn't interfere quite as much, but it's a little bit longer of a treatment course than, say, a fluoroquinolone. So you can do doxycycline. Otherwise, you could do, for a basic CAP, even in a healthy patient, you could do one of the comorbidity ones. There's nothing wrong with going straight to here. And that's why people use Levaquin or levofloxacin, probably the most common drug prescribed for CAP. It's really, really easy, which even though I have a little bit of mixed feelings about fluoroquinolones in general, and some of my colleagues hate them, I do think they have a really good role here because it's a once daily regimen for 5 days for CAP. And if I had pneumonia, that's the one I would want, just because I'm not going to remember to take 2 drugs twice a day for like a week. It's just not going to happen. I'm a bad patient. You can scold me later, but I'm going to take the once daily for 5 days. And it's a pretty good treatment option. Fluoroquinolones just have a lot of weird side effects that possibly could or could not happen. But in healthy people, for 5 days, the odds of those causing problems are very unlikely. So I like fluoroquinolones personally. I think they're a great choice as a respiratory fluoroquinolone if you're treating CAP. The other good choice, which is, again, equally as good and probably the more appropriate channel if you want to look at the whole safety profile thing, azithromycin plus something else. So you need something to pick up that the strep pneumo coverage. And that's either going to be a second, third generation cephalosporin. That's probably the most common choice we pick. But you technically could use amoxicillin or augmentin high dose, and that'll cover strep pneumo as well. So one of those combinations, but you just can't do azithromycin by itself. You have to add something onto it. Usually you're looking at about 7 to 10 day treatment course, depending on the agent you pick, and then it gets 5 days for Levaquin. So where it gets a little confusing, let's say you want to go with option, well, let's say this is option 3 here. You end up prescribing somebody azithromycin, and if you guys ever taken a Z-Pak or looked at Z-Pak dosing, you take 500 on the first day and then 250 once a day for 4 days, and that's the Z-Pak. And then on top of that, you'd have something else you're taking at a different interval. So it gets a little complicated, I think, for most people to remember, especially if they aren't used to taking a lot of medications. So just reminding people to set reminders on their phone or get a pill box or whatever they need to do. But it is a little bit of a wonky treatment course. It's not cut and dry. Okay, let's say you're looking at a hospital admission. So this is a patient who comes into your urgent care or family practice or wherever, and you're like, you need to go to the hospital. I'm going to refer you. It's basically the same thing. We're looking at azithromycin plus third-gen cephalosporin. We kind of skipped the whole amoxicillin augmentin thing. That kind of falls off at this point. And you could still do a fluoroquinolone as monotherapy as well for a non-ICU admit. IV Unison or ertapenem could be alternatives potentially, but they probably aren't as preferred in this case. Ertapenem might be a nice choice if you have allergies or intolerances in patients. Remember, carbapenems have very few cross-reactivities with your penicillins and beta-lactams as a whole. So if you wanted to do azithromycin plus ertapenem, that would be just fine if, like, let's say they had an allergy to cephalosporin and, you know, they're 94 and they're kind of a frail old person. You don't want to risk rupturing their tendon with Levaquin. Fair enough. Then ertapenem would kind of be your second choice after that. Usually for a non-ICU admission, you're still probably going to do IV therapy. There's a number of things that might factor into this, so it depends on what else they're looking. How sick are they looking? Are they tolerating oral things okay? That could be some questions to ask yourself. Another thing is just to remember is that, like, fluoroquinolones, for example, have awesome bioavailability. They're like 95% bioavailable, so 1-to-1 IV to PO, which is another reason why they're really handy. Like, let's say you just started somebody on IV Levaquin, you can convert them to PO and discharge them 2 days later on the exact same drug. Where if you started somebody on azithromycin and ceftriaxone, you have to figure out what cephalosporin to replace the ceftriaxone with, because you're not going to discharge somebody usually on an IV regimen unless there's extenuating circumstances. So just something to consider. Another reason why fluoroquinolones tend to be pretty popular for that reason. Okay, so PO, I think there's more evidence coming out to push towards treating some of these less severe, like non-ICU admissions, not just with CAP, but in things in general with oral therapy, just because looking at the agents out there that do have really good bioavailability, so your fluoroquinolones, cephalosporins usually have pretty good bioavailability, but overall, I think there's a trend going that direction right now. We'll see if guidelines pick some of that stuff up, but that's just what I have to say for the time being. If you got ICU admission, you're looking at a very similar treatment strategy, but you really don't consider oral at all. You want to make sure, the reason is even if your patient might be able to tolerate oral therapy, you want to guarantee that all your drug's getting into the person. A physician kind of explained this to me. It's like, well, I don't know if that person's GI tract's working optimally, especially if they're critically ill. So even though you're right that it would probably absorb okay, I want to know 100% sure that my antibiotic got in there at the full dose. And I think that's a fair strategy. So the guidelines will recommend IV-only therapy for an ICU admission, or a severe hospitalization is what they technically call it. So you're looking at azithromycin plus a third-gen cephalosporin, just like we had. Levomoxifloxacin. In this case, you actually use this as a supplement to azithromycin. So that's one of the big differences. You still do combination therapy if you're going to go with the advanced fluoroquinolone. So that's the big difference between the non-ICU and the ICU patients. If you have a severe beta-lactam allergy, consider a more advanced generation carbapenem, like imipenem, and then you would add one of the things to cover atypicals. And remember, the reason why we can use our fluoroquinolones as monotherapy in the less severe people is because they cover which particular pathogen we're concerned about. That's the reason why we use azithromycin. What's that group of drugs called? Or group of bugs called, I should say. Sorry. Atypicals, right? So the atypical pathogens are why we're doing this at all. So that's the big thing we need to add on. So in this case, with the ICU patients, Levaquin kind of gets taken to a backseat and says, okay, you're just basically covering the atypical pathogens, although it still has great strep pneumo coverage. You can kind of think about it as it'll double cover strep pneumo with whatever third-gen cephalosporin you add If you do have a Pseudomonas concern, so if your patient has a recent hospitalization, if they're healthcare, I should say hospital acquired, or if they're heavily immunocompromised, you might consider something more aggressive right off the bat, which would be like azosin, cefepime, imipenem. You still need to cover your atypicals. None of these drugs cover atypical pathogens, so you still have to add usually a fluoroquinolone on board. You could do possibly azithromycin, but I think the idea in this case is that you add Cipro or levofloxacin because it double covers Pseudomonas. So those two fluoroquinolones add Pseudomonal coverage. If that is your concern, you have two drugs trying to attack that specific bacteria. You could, yeah, this gets a little complicated. The other option you could do is, sorry, my computer just shut off. There we go. You could do an aminoglycoside and azithromycin. That gets really messy. I think choice, this one would be the preferred option here. And then double coverage, again, recommended. For a while, double coverage is kind of been controversial on and off on whether you really need to have two anti-Pseudomonal drugs to cover Pseudomonas, but for the most part, people recommend it. So that's where it's nice to have the levofloxacin on board or the ciprofloxacin if you have the other one of these more broad spectrum agents, because you are getting that double coverage and you're getting your atypicals in the same pathway. Whereas if you did like an aminoglycoside, that's going to double cover Pseudomonas, but doesn't do anything for atypicals. So you still have to add an azithromycin or a fluoroquinolone on. And again, it just adds it's a few too many antibiotics for my comfort zone. Yeah.
Is it controversial because of the whole resistant stewardship thing?
Well, yeah, that's one thing. It's like, do we really need it? But I think most of the studies tend to show positive benefits and positive mortality benefits to double covering Pseudomonas. Pseudomonas and its cousins are some of the most emerging pathogens that are getting more difficult and difficult to treat. So better odds if you have two drugs on right away. Yeah, that's exactly right. It's stewardship related, and it's breeding more resistance by exposing people to extra drugs that they don't need to be exposed to. MRSA concern. If you have MRSA concern, add vancomycin, linezolid. So if I have a patient who comes into the ER and they have a history, they were just in the hospital like a week ago and now they have a really bad pneumonia, I'm probably going to treat them with vancomycin, zosyn, and like a fluoroquinolone. That's probably what they're going to go with. Start broad. That's kind of the ER philosophy. You start broad and then let the people on the floor work their way down. So you can figure that out with cultures and how people are responding, but that's usually the strategy you'd go with. So you can see that CAP from a hospital admission goes from basically the exact same thing as a outpatient to all the way to like basically a severe sepsis profile. It really depends on how sick the patient is and their history, but usually you're going to fall within this realm. And even for patients who are almost looking septic with pneumonia, if they don't have a good indication for Pseudomonas or MRSA coverage, you can treat a septic pneumonia patient with like a azithromycin, ceftriaxone. There's nothing wrong with that. You just would want to document in your note that there's no real risk here for Pseudomonas or MRSA, because those would have to be usually opportunistic in a patient for a pneumonia, and you're going to have specific exposure probably to see that in most cases. That basically, it's pretty straightforward. Usually you're looking at hospital bugs, which are going to be, again, those Pseudomonas, MRSA type guys, and you're going to treat it broad spectrum. So if somebody gets a pneumonia on a ventilator, vancomycin right away, or some equivalent to that group. Same thing with hospital-acquired pneumonia. COPD exacerbations, I'm just going to touch on this very briefly. We'll come back to this a bit during respiratory as well. But you can treat this from an infectious disease profile. There's been a couple studies out there that have looked at antibiotic use long-term to prevent it. It doesn't really show anything good. But if you do have somebody coming in with a COPD exacerbation, they will usually do some sort of antibiotic therapy. So like a basic doxycycline is probably my favorite drug. Again, you could use azithromycin plain here, but to me it doesn't make a ton of sense because strep pneumo is a potential pathogen. So I'd stick to an advanced gen cephalosporin or a doxycycline. Bactrim actually has some data too. Bactrim does cover strep pneumo, okay. Age greater than 65. Pulmonary function tests looking bad, more than 3 exacerbations a year. Maybe up the ante a little bit and do just a fluoroquinolone. So you treat it almost like CAP in this case for patients with more significant risk factors. All right, let's take a quick break. Actually, you know, let's do cardiac. Get a little more than halfway through. Okay, endocarditis. I don't want you to spend a lot of time on endocarditis. It's super complicated, and it's a specialty type thing, so don't worry about it too much. I just want to mention it and have you have some idea of what endocarditis is and what we use to treat it. Usually endocarditis patients are going to be people with poor oral hygiene or who had a dental procedure that had some sort of infection from there. IV drug users, especially if you have a young patient with endocarditis or a young patient who's septic with the bacteremia. Did they shoot heroin? That's probably the reason why. What happens is you get some sort of a bloodstream infection, bacteria seed on the heart valves, and they form kind of a biofilm on them, which impairs the heart's ability to pump blood correctly. And it's mostly caused by gram-positive bacteria. So strep viridans and Staph aureus are your two most common drugs. And there's a group of other kind of common things like Enterococcus, which is mostly a fecal-related bacterial. See Enterococcus a lot in UTIs and things like that. Coag-negative staph Hasek organisms, which again are kind of a weird group of things that I do not care you know. Criteria, we usually look at prosthetic versus native valve, and the only reason is we pair our treatment course based on that. Blood cultures are almost always positive in patients. It's actually pretty easy to figure out what they're being infected with and target your antibiotics that way. Because if somebody has a vegetation on their valve, it's probably throwing it all over their bloodstream, right? Makes sense. Empiric therapy, usually we're looking at staph, strep, enterococcus, so focusing mostly on the big gram-negative or gram-positive bacteria. Basic therapy, vancomycin alone might be enough. Penicillin actually covers strep viridans really well, but usually in most patients you're going to cover Staph aureus too. So you're looking at like a vancomycin plus some other stuff to see what's going on, and really the cultures are going to lead you there. So I don't want you to know a whole lot about endocarditis other than there's different pathogens and we would tailor our treatment specifically. We do use kind of an odd antibiotic called rifampin, which is more associated with tuberculosis therapy. The reason why we use rifampin is it can help penetrate biofilm layers. It's a kind of a unique antibiotic that has synergy with drugs like vancomycin and aminoglycosides as well, and together they can help each other out. But other than that, don't really care a ton about this. So just know, basically, for endocarditis for the exam, it's mostly gram-positive, and that we'd usually start with vancomycin, possibly plus or minus like a cephalosporin. Okay, let's take a 5-minute break and we'll come back and do the rest of the topics. And he never got done on time. It's like, just don't tell me that. Okay. I had a good question about aspiration pneumonia. It's a really common presentation, and it's usually kind of like a cap, but you have stomach contents in question too, which have anaerobes in them. So usually for an aspiration pneumonia, you do something a little bit more broad spectrum, like a Zosyn or a cefepime, metronidazole, something like that would be appropriate for asp pneumonia. You don't usually need MRSA coverage for aspiration pneumonia, but you could add it if the person's looking really sick. The odds of having Staph aureus in the GI content, probably pretty rare, but you know, never know. All right, meningitis is another kind of specialty thing that I don't want to spend a ton of time on. It's not super complicated, so I do want you to know the general treatment strategy, but this stuff is just for background. So meningitis is fatal if it's not treated in a lot of cases, so it's something we are pretty aggressive with if we do identify it. So usually if somebody comes in, headache, fever, stiff neck upon presentation are kind of like the hallmark things. Most cases are viral, which is called aseptic meningitis, and we usually just use IV acyclovir for that, which is an antiviral we'll talk about in a little bit, different lecture. But without treatment, without knowing, we usually do a couple things first of all. So we'll do a lumbar puncture, get a CSF culture going so we can see what type of species it is. Usually we can get a gram stain on it pretty quick so we know what we're dealing with right away. Bacterial meningitis is usually only caused by a couple different bacteria, so it's pretty straightforward as far as treatment goes actually. CSF findings, I always remember this, and maybe this helps you or maybe it doesn't, I don't know. But if you have bacteria in the CSF, they're eating glucose and creating proteins and byproducts. So you're always going to see low glucose, high levels of protein. White blood cells are also going to be elevated with mostly neutrophils. Now, CSF findings are not an absolute diagnosis, but a pretty good indication. And then your blood cultures are going to be the other thing that you usually will see as a positive. So those different things are going to be your diagnostic tools for narrowing your therapy. But usually we're just going to start high-dose antibiotics pretty quickly. And for the vast majority of patients, it's going to be ceftriaxone plus vancomycin. The differences would be kids. So kids under like 2 years are usually going to get, kids under a month are going to get ampicillin plus cefotaxime, which is, for reasons I'm not going to go into, we don't give ceftriaxone to really little kids. It has to do with the way they process medications. But we give cefotaxime, which is kind of a third-gen alternative. We don't give vanco to less than 1 month olds because staff, as far as needing to cover some of these other organisms like strep pneumo, you don't really need that in little kids. Adults over 50 years old, we also add the ampicillin back on, but we keep the vanco. And that's because they're more likely to get different types of organisms, specifically listeria, which is covered really well with ampicillin. Now, a lot of this is double coverage, and it's a little bit duplicative, and it's done by specifically for that reason, because you don't want to take any risks when you cover somebody's central nervous system. So for the vast majority of patients, we'll see, well, I guess you could make an argument that you might see more elderly. But anyway, most people you're going to see are going to be a vanco plus a third-generation cephalosporin. Pretty basic. You don't really need to go beyond that. You aren't going to see Pseudomonas in the CSF. Maybe really rarely. I think I've seen a couple cases of that, and you might be able to use like a carbapenem or a cefepime to cover that. Like if you have a head trauma, that's a little bit different. So you'll see here they'll add like vanco plus cefepime, vanco plus meropenem. Meropenem is the preferred CNS penetrating agent there. And then neurosurgery is kind of similar. So that's where it gets a little more broad spectrum once you add some sort of a traumatic introduction there. If it's more of a non-traumatic related meningitis infection, that would be the basics up here. So that's the big difference between these two sections.
So do we need to know this chart?
You need to know. Need to know the adult treatment. Yes. So if you have an adult with meningitis, vanco plus a third-gen cephalosporin. That's what you need to know. And if they're over 50, you'd add ampicillin. I would know that caveat too, because you're going to see elderly patients as well. Maybe peds. I won't get into peds right now. I don't care. You know the peds treatments. This is a little bit cleaner of a slide, I think, just to show you what lines up with what and why we treat certain things. So again, both drugs are going to cover your strep pneumo. Third-generation cephalosporins cover Neisseria. Neisseria is the one we get vaccinated for, associated with people living in high-density housing, like military, dorm housing, things like that. Listeria is going to be covered by ampicillin, and then Haemophilus would be third-generation cephalosporin as well. So those are really the 4 bugs we're looking at, mostly covered all with one drug. We add the vanco on for good measure. And then for older adults who might get listeria, that would be the ampicillin as well. So that's it looks a little complicated, and it's definitely a serious illness, but it's fairly basic from an initial treatment strategy. Anyway, don't worry about the alternatives. I don't want you to know that for meningitis. It gets complicated because the CNS penetration is a little more advanced than I want you to have to understand for this exam. Okay, GI tract stuff. Helicobacter pylori, excuse me, peptic ulcer disease. So anybody with an ulcer is going to get tested for usually an IgG test. So it's an immunologic test to see if they have antibody produced to Helicobacter. And if they do have that positive, we usually treat them with standard triple therapy. Kind of an odd treatment. It's amoxicillin 1 gram BID and clarithromycin 500 milligrams BID. Why they came up with that, I don't know, but that's what it is. 10 to 14 days of therapy, plus you add something called a proton pump inhibitor, which are drugs like Prilosec, Nexium, like omeprazole would be the generic name of those. We'll talk about those later, and I don't care you know that for this test. Just know the antibiotics. If you do have a pen allergic patient, you could substitute metronidazole, interestingly enough. So you do metronidazole plus clarithromycin for that standard triple therapy. There's something called quadruple therapy, which is really just 2 different antibiotics. So it's metronidazole plus tetracycline. You get the PPI as well, and then you add Pepto-Bismol on top of it. Bismuth sulfolate is what is in Pepto-Bismol, and it does have an antimicrobial effect in the GI tract topically, so you can use it. It's sort of like you start with triple therapy, and if that doesn't work, you try quadruple therapy. That's how it goes. There's another weird therapy called like a load regimen, which has levofloxacin and some other odd stuff in it. I won't talk about that because I've never seen it in practice. I'm sure maybe they do it in specialty areas or areas where there's high resistance. But you can see it's about 20% first-time failure. And again, then you could go to a more advanced regimen after that. So it's not the best treatment strategy we have for anything, but yeah.
Do we have to know, like, amoxicillin 1 gram BID?
No, you don't need to know doses unless I specifically tell you to. There's only a couple times in the entire course where I ask you to know a dose. And one of those would be STDs, which we'll talk about here in a second. And some of the other ones are like Tylenol max doses and things like that. But I'll make it very clear if you need to know a dose. Good question. Thank you. Just an algorithm in case you were confused by what I just said. All right, intra-abdominal. I don't know. I should really make a slide for this, but I like the guidelines because they do all my work for me. I know it looks like a lot of information, but it's really just a lot of different alternate regimens. For intra-abdominal infections, so you've got Table 2 and Table 4 on this slide. Table 2 is extrabiliary complicated intra-abdominal infections. So you have community-acquired infections, single agent and combination, and then you have mild to moderate and high risk. So these would be things like your appendicitis, your diverticulitis, stuff like that. And really what you want to do is cover E. coli and cover Bacteroides, which is or Bacteroides fragilis, which is anaerobic bacteria. So basically, when you're thinking about this, basic gram-negative coverage and basic anaerobic coverage is all you need to cover a mild to moderate severity community-acquired infection for intra-abdominal. So again, appendicitis, diverticulitis, those drugs are fine. What we like to do for most patients, if they're going to get admitted in IV therapy, we give ceftriaxone and metronidazole to almost everyone. It's a really cheap combination. Some people really like to say, oh, let's just give Zosyn to people. Well, don't give Zosyn to somebody if they don't need it. Zosyn's a more severe infection. If they have a burst appendix, Zosyn's probably more appropriate. Or if they're really, really sick or looking septic, certainly go with the other column here. But just know that I think people get in this mindset that, oh, I can give a carbapenem and it's a single drug regimen that covers my gram-negatives and my anaerobes. That doesn't mean it's better. It's actually going to be more broad spectrum and possibly pose resistance to the patient in the future. We always want to reserve carbapenems if we can at all possibilities. So in this case, try and not use them if you can, and don't use them for convenience. Especially people love ertapenem because ertapenem has this nice long-acting duration to it, and it's just, again, don't fall into that trap. So that's all I'll say. So again, combination therapy is certainly fine, and is preferred in most cases to a single agent, just because, again, it makes more sense. And if you want to take cost into perspective, ceftriaxone plus metronidazole is like 1/10 of the cost of 1 dose of ertapenem. So anyway, if you go down to the bottom table, you have extrabiliary infections, and really the difference here is that mild to moderate severity, you take away the anaerobic coverage, so you don't need metronidazole on board with it. Once you get more severe things, you do add the anaerobic coverage back on, and that's basically the same thing as the first table. So again, there's a lot of drugs on this table, but really what I want you to remember is the severity differences, and that you cover with both gram-negative and anaerobic coverage for your antibiotics. Yes?
Terms extrabiliary and intrabiliary.
It has to do with where in the GI tract it is. Now, as far as anatomy goes, you're testing me a little bit. I don't really know. I'm not sure. I think, as far as I know, biliary infections are really just cholecystitis. I don't know of another one that's specifically a biliary infection. I think everything else would probably qualify as extrabiliary, but I could be wrong on that. So the vast majority of intra-abdominal infections, you're going to look at the top table. That's what I'm much more concerned about. Yeah. So basically, I'll phrase it in a different way. If you have cholecystitis, then you don't need to do metronidazole in a mild patient. Basically, you can cut off your anaerobes if you don't need them. That makes more sense that way. I'll just throw this out there. A lot of people like to just use ciproflagyl for these. Cipro doesn't have great E. coli coverage, so I'd recommend not using that, just as a specific thing. I think they actually, do they have it on here? I don't think they have Cipro on here, do they?
They do
Under mild to mild. Oh, yeah, there it is. So, yeah, down here they say increasing resistance to fluoroquinolones. We do have, fluoroquinolones aren't awful against E. coli. That's probably like 85% coverage rate, which isn't great. Cephalosporins like ceftriaxone are like 98%. So it's a basic sure thing it's going to cover the E. coli. And it's usually less, it's once a day, doesn't have renal adjustment. You guys watched my lecture last week. It's got basically, it's a better profile drug all around. So that's our preferred agent in most cases. Okay, C. diff, associated with healthcare exposure and antibiotic use. However, we're seeing a lot of community-acquired C. diff as well. Why, I'm not entirely sure. it can be mild to moderate, cause severe pseudomembranous colitis, leading to profuse diarrhea. Either way, it's not a pleasant experience. You want to stop the offending antibiotic therapy as soon as possible. You might not be able to, though. Let's say somebody's in your ICU and they're septic or they have a pneumonia. You don't want to stop that because that's probably what's saving their life. So you have to just treat through it, and it's an unfortunate complication of the nature of what we're doing here with antibiotic therapy. The other thing we do is wash our hands. So transmitting stuff room to room in a hospital is one of the biggest sources of C. diff spreading, and so hand hygiene is super important. And I know you guys probably know this, and I'm preaching to the choir, but it's worth saying, I think. So anyway, when you see those signs on the door about hand hygiene, it's actually legitimate. You want to follow it. Antibiotic treatment regimens, vancomycin, PO, QID. We used to be able to use oral metronidazole as a first line. So the only reason I bring this up is because this was a recent guideline change last year where we don't use oral metronidazole anymore right away. We go straight to vancomycin oral. Now, the big difference between using vancomycin oral and versus IV, you can't transfer them, right? They're one or the other. They don't cross over. So sometimes people will say, well, I'm going to give somebody IV vancomycin for C. diff. It doesn't work that way. IV vancomycin doesn't get into the GI tract very well. And alternatively, vancomycin oral doesn't get outside of the GI tract. Think about it like topical antibiotic exposure within the GI tract itself. It doesn't go anywhere else. You might get some mild systemic exposure to vanco, but not enough to be clinically significant. So vancomycin oral only used for C. diff. It comes as a capsule form. We usually compound it as like a solution because it's really cheap. So what we do is we buy these big vials of IV vancomycin and we make a liquid out of it and draw it up. So that's what most compounding pharmacies will do too. And most like Walgreens can even make this because it's so common. Yeah, the capsules are probably like 20 times the cost of the solution. So if you prescribe capsules, they'll probably call you and ask you to prescribe the solution. Let's see, fidaxomicin is a newer agent. So if you are vancomycin resistant or you don't respond, that's where things get really tricky. I don't want you to know anything about fidaxomicin other than that it's an alternative for vanco and C. diff cases. ID providers are a little bit all over the board on this and what they want to do if vanco doesn't work right away. So usually vanco is dosed 125 milligrams QID immediately. And if that course doesn't work, then you usually increase the dose. So they might try like a 500 milligram QID vanco. That doesn't work. They might try like a long-term vanco taper. I've seen those too, where they dose somebody high and then kind of have them on this really long, like weeks worth, where they gradually decrease their dose of vancomycin. Or they might go to fidaxomicin. Yeah.
How long do you typically wait before deciding to use that?
Oh, usually it's a 10-day course. Yeah, I don't have that on here, but yeah, usually it's a 10-day course for C. diff. IV metronidazole can be used as well in adjunct to vancomycin, and that's usually for a severe case. So somebody's hospitalized and they're on IV or on PO vanco, you could add the IV flagyl on board too. But we really just don't use oral flagyl at all for C. diff anymore. It's not thought to be very effective. Finally, lots of other things with C. diff. Probiotics, do they help? Studies say no. It's not going to hurt the patient, but it's not going to help them get better. And then ultimately fecal transplant, which is actually where you take the fecal matter of somebody, usually a relative, and then I think they actually like freeze dry it and put it into capsule form or something weird and gross like that. And then the person actually consumes it, and then that actually is transplanting the fecal matter, and that's actually a very effective way to treat C. diff. So a lot of times people who have tried these vanco tapers or tried really high dose vanco or even tried fidaxomicin not getting results, that's what they go to. That was actually, I think, pioneered in Duluth, believe it or not. So claim to fame, Duluth. Yeah. Other enteric pathogens, this gets kind of tricky. I just want you to take home a couple points from this slide. First, that a lot of these things are self-limiting, but there are a couple we treat. So salmonella, usually self-limited, but if it's severe enough, like more than 9 stools per day or the patient's febrile, we usually treat with Cipro. Shigella, also treated with Cipro. Campylobacter, usually self-limiting. We only treat severe cases. Usually, what do we treat? Cipro. You see the fluoroquinolone in there, just think Cipro for all of this. You could have alternates here, but usually we're going to go Cipro for first line. E. coli, it's the standard traveler's diarrhea. If you've ever traveled to someplace doesn't have great water quality, they probably gave you a prescription for Cipro, and guess what? E. coli covers Cipro somewhat. Not as great like I just said, but it's okay. What you don't want to treat is enterohemorrhagic strains of infectious diarrhea. So if somebody has diarrhea and you give a stool culture, and it comes back growing EHEC or the 0157 strain. You might have heard about this in the news. Every time beaches get closed for E. coli in the summers, occasionally sometimes that happens, that's the isolate that can cause bloody diarrhea. And it produces something called Shiga toxin, which people confuse with Shigella. It's actually E. coli that produces Shiga toxin, not Shigella. And it's something that if you gave antibiotics to, it lyses the bacterial cell, which increases the toxin exposure, which can make the disease quite a bit worse. So it's actually just supportive care in that strain. So that's why the stool culture is really important. If somebody has some sort of suspected enteric pathogen, one, you want to know if it's C. diff or not. Two, you want to know which one of these things it might be, if it's any of them. And then you direct your treatment that way. So again, fluoroquinolone, Cipro, preferred drug for different types of infectious diarrhea that aren't C. diff, and then the enterohemorrhagic strain of E. coli, do not treat it with antibiotics. Those are the two takeaways really I want you to get from that. GU. All right. UTIs, the other, I guess, in addition to CAP, probably the other most common thing most people will see in their careers no matter where they practice. So dysuria, increased urinary urgency and frequency. Elderly can present a little bit differently, especially if they're demented. They might not be able to express symptoms normally, so they might have an altered mental status component to it. Flank pain or fever, likely indicative of more of a systemic infection like pyelonephritis, and we treat that somewhat differently. Asymptomatic bacteriuria. So if you culture somebody's urine and they have zero symptoms, we do not treat it except pregnant patients and people undergoing like a traumatic urologic intervention, or if they're really high risk. And what that might be is up to you. Like maybe you're like, this person's had them in the past, and I don't know, I don't want to risk it or something. I don't know. It's up to you. But generally speaking, don't treat an asymptomatic patient. The problem we run into a lot of times is, like in our lab system, what happens if you do a urine analysis on a patient, it'll auto-reflex to a urine culture. We can't suppress that. So even if the urine analysis looks okay, it might reflex to a culture. That culture could come back growing some E. coli. If that patient was asymptomatic, then you're with the question, okay, I know they're growing E. coli, the UA looked okay, how do I go about this? And that's oftentimes where, like, my team on the ED fell in. We followed up on a lot of these cultures and had to wade through that. But generally speaking, the patient's doing fine. We don't treat them unless they meet those criteria. Colonization versus infection. Catheterization in patients is really complicated. I highly recommend either following up with their urologist or infectious disease before treating somebody who has a history of substantial catheter-associated pathogens. Usually, one, they're colonized, so it's not an actual infection. And two, they're growing really weird stuff and things with lots of resistance patterns, so giving them something is probably not even an option. Sometimes you look at these patients' culture reports and they've got like Pseudomonas resistant to everything oral. So it's like, do we give them IV ertapenem at home, or sorry, ertapenem's a bad choice, IV imipenem at home, or what's the other option there? So again, get involved with the right people. Don't just prescribe somebody something because you see it there. I know that sounds maybe like I'm trying to be, like put you guys down or anything like that. But I've seen it happen a lot where people are like, oh, what antibiotic should I put down? And it's like, oh, this is way too complicated for us to manage. We need to get the other person here involved. And they're like, great, call ID. And I'm like, I don't want to call ID. But anyway, that's the case. So I highly recommend just consulting your friends on those more complicated ones. Anyway, E. coli is the pathogen here, and it's almost always going to be the pathogen for an uncomplicated UTI. So that's what we're treating. The other things you can see are Klebsiella, Proteus. Staph saprophyticus is gram-positive. That if you see it on a culture, they usually don't give you any sensitivities, and they just say, like in a line anyway, I don't know what other labs do, but they just say, like, Staph saprophyticus usually responds to basic UTI therapies. Like, oh, okay, that's helpful, kind of, right? You're just shooting in the dark, and hopefully you hit it. But usually, yeah, the basic 4 options should cover Staph saprophyticus. It's kind of a weaker form of staph that apparently is pretty susceptible to most of this stuff. 4 basic options: nitrofurantoin, Bacterium, cephalexin, and Cipro. I highlighted or bolded nitrofurantoin and cephalexin because they're the preferred options. Bacterium and Cipro have poor E. coli coverage in comparison. You're talking about like 80 to 85% versus 95% plus coverage with the other two. You always want to follow the cultures. If you have the culture data, you can always adjust therapy. Happens all the time, so don't feel bad if somebody comes back resistant. Not that I don't think you'd feel bad, but maybe you would. I don't know. Don't take it personally. The bacteria doesn't have a vendetta against you. It just happened to be resistant in that patient. It's really hard to predict sometimes. You might get somebody who comes in and they're relatively healthy and they come back growing Pseudomonas, and you're like, who could have thought that happened? Well, here we are. So you have to follow the cultures, but of course the mass majority are going to be E. coli and are going to respond pretty well to these things. The one downside to our preferred regimens, as you can see, is their longer courses of therapy. So I think that's why people are like, oh, I really like Bactrim and Cipro because it's only 3 days. And yes, that's nice. But at the same time, you know, if 80% of your patients are covered, 1 in 5 will come back needing a new antibiotic. It's probably not ideal for your practice. Other things, tricks I have up my sleeve, second, third generation cephalosporins in resistant cases usually almost always cover E. coli 100% of the time. Other thing, doxycycline usually won't show up on a urine culture review, but it usually covers E. coli pretty well. It's kind of one to keep in your back pocket. Pregnant patients, macrobid or cephalexin are good. People considered complicated would be male patients, just more complicated anatomy. Pregnant patients, chronic catheterization. Usually you're going to treat with similar options, but longer courses of treatment and higher doses. Generally, we don't use nitrofurantoin, especially in male patients, because in male patients, you can't always rule out a prostatitis at the same time. And if that's the culprit of their symptoms, nitrofurantoin just really only stays in the bladder. It doesn't get into the prostate gland at all. And so you aren't going to get any tissue penetration. So you aren't going to treat your source. So usually in like a male patient, we'll probably stick to Cipro. Even though it's not ideal, it does have better tissue penetration than our other agents. Cephalosporins might be okay too, but Cipro is usually preferred for a male patient. So little caveat there. But like assuming you've got, let's say, a healthy woman, 20 to 40 years old, not pregnant, you're going to treat with one of these basic options, and that's going to cover it for the most part. I like nitrofurantoin especially because it covers a bunch of weird gram-positive things too. So it covers Enterococcus. It can cover even MRSA in some cases. So if people have an odd bug growing, it kind of has your bases covered. Whereas if it comes back growing Enterococcus, and that's not covered by any cephalosporin. So you have to switch gears at that point. And that's one of the downsides. Again, nitrofurantoin is a really great drug for just plain UTIs. It's pretty much perfect. It doesn't get into the bloodstream, really no side effects to begin with. So it's a great choice. For pyelo, basically pathogens, E. coli, same thing. It moved up the urinary tract into the kidneys. Macrobid is not good for kidney infections. The only time I've ever seen this done, one time, well, occasionally, sometimes in OB patients, they'll give macrobid for a pyelo just because there's no other option, really. They might have allergies or something, but definitely not ideal. We want to do fluoroquinolones usually in these patients. So again, not our preferred option because of its E. coli coverage, but in this case, it's going to get into the kidneys a lot better than a beta-lactam drug. Now, you could give a longer course of a beta-lactam. What we do instead usually is like an IV or IM ceftriaxone dose while they're in the clinic or while they're in the urgent care ER, and then discharge them with like 5 to 7 days of PO, Cipro, or levofloxacine's an option too, certainly. So you could do one of those two. And then the ceftriaxone is kind of a plus minus. It's if you want to do it. You don't have to do it. You could just send them home on levofloxacin or Cipro, and that's fine. Levofloxacin, I think, is getting more popular as the pyelo drug of choice. It doesn't cover E. coli any better than Cipro, but it's that once daily regimen that makes it a little more convenient for people to take. So that's the only reason. And again, you can use the other options, Bactrim, cephalexin, ceftriaxone, advanced generation cephalosporins, but you're looking at like a 2-week course total. So you extend your course by double what it is. Pregnancy, we stick to cephalosporins if we can. Nitrofurantoin has some issues with pregnant patients, but it can be used in certain trimesters. I'm not going to get into that right now, but just know that's not necessarily the preferred option, but it generally can be used in pregnant patients. But cephalosporins can be used in any trimester without really any risk to the fetus, so that's our preferred option. All right, I found this on Google. I don't know if it's real or not, but this is an old like World War II propaganda poster. Don't spread STDs. Okay. Bacterial STIs. So again, the bolded doses, I do want you to know for the exam. I think it's important to know STI dosing. It's going to come up in a lot of different practices. Our 2 major STIs that are bacterial are chlamydia and gonorrhea. Bacteria next to their names there. For just chlamydia infections, you can treat with azithromycin 1 gram PO times 1 dose. Doxycycline, a 7-day course, is a backup. And yes, you might hear providers say, and certain people say, doxycycline is more effective than azithromycin 1 gram 1 time. True, slightly more effective, but not so much more that we want to give somebody a 7-day course that they aren't going to finish. The thing about azithromycin 1 gram PO is you give it to them in clinic or in hospital or urgent care or wherever, they can take it right in front of you and you know they consume the whole course. Whereas the doxy, I don't know, what if they only take 3 days of it, then they're right back where they started. So that's the big thing, is compliance. And I make a big deal about compliance, but it's true. People just don't take their meds, especially if you have like a young person who's maybe not used to taking medications and they prescribe them 7 days and they feel better after 2, they just stop it. It happens all the time, even if you tell them not to. So again, one-time doses are really ideal in the STI world specifically, and in general, but STIs certainly. Gonorrhea, ceftriaxone 250 IM times 1 dose. The difference being is that we don't treat gonorrhea with monotherapy. We always add azithromycin or the doxycycline regimen in addition to it. Gonorrhea has a lot of emerging resistance, and the ceftriaxone dose kind of ratchets up over time. But if you add azithro onto it or doxycycline, you get a synergistic effect, and they both have some coverage against it. In most cases, if you suspect a bacterial STD, you're just going to treat with both right off the bat, even if you don't have testing. Don't gamble and say, oh, I think you just have chlamydia, we'll just give you azithromycin. Yeah, probably a bad idea. Give them a shot of the ceftriaxone just to cover your bases. Because just as another thing I used to do in the ED is follow up with STI tests, and trying to get a hold of people who had like a gonorrhea come back positive and weren't treated, it's almost impossible. Like their phone numbers never work, or their voicemail's full, or they don't call back. I'd say it's maybe like a 75% chance you don't get a hold of that person, which is a little scary, right? So treat both once, and then you don't have to worry about it. You can sleep well at night. Trichomoniasis is a parasite infection, which you can treat with metronidazole. I don't always see this routinely done. You can do on a vaginal wet prep. You can actually see if there's trichomoniasis growing, or sorry, trichomonas, I should say, is the organism. And bacterial vaginosis is not a bacterial STD per se, but it can be sexually transmitted, and that's also covered with metronidazole. So we use metronidazole, either PO BID for 7 days, or you could use the topical metro gel. That's a great option for pregnant patients because you don't get any systemic exposure using the topical metronidazole. What else did I want to say about these? I think that's it. I thought there was one other thing in my head, and I'm not remembering it right now. We'll move on. Any questions about STDs? Thinking? Okay. All right, syphilis is a whole other beast. It's got a bunch of different phases. I actually think it's really similar to how Lyme disease presents, even though it's not. It's kind of a spirochete, but not quite the exact same thing. So you have different phases, and depending on how you treat it, it can get much more severe. Al Capone actually died from syphilis. Interesting factoid there, which is why he's on the slide. Primary syphilis, 2 to 3 week incubation period. Patients get something called a chancre, I think is how you pronounce it. It's an ulceration present at the site of the infection. It's apparently painless, so people might not notice it, especially if it's in a place they can't see. Bacteria is widely disseminated at this point, so if you have the chancre, you need to be treated. Secondary syphilis can happen weeks to months after that initial chancre appears. It's a nickel and dime type rash like you might see on this person's hand here. Progressing severity cause alopecia, musculoskeletal like arthritic-like pain, GI, neurologic pain, and neurologic symptoms as well. Late is tertiary syphilis, which is usually either neurosyphilis, which is full neurologic involvement, or cardiovascular involvement. Very hard to treat, but the treatment's actually pretty much the same no matter where you are. I found this on the internet. This is a stuffed spirochete, so it's kind of a cute syphilis, I guess. I don't know if you can actually buy that or not, but I found a picture of one. Anyway, yeah, it's a good stocking stuffer. Early treatment. Again, syphilis treatment is super basic. So the nice thing about syphilis is it's really responsive to penicillin. In fact, that's the gold standard. Give really high dose penicillin. Early treatment. It's double the dose of strep throat, in case you're paying attention to that. So you actually give like 2 big shots of it. It's a IM one-time dose. Again, really easy to treat early on. One-time dose, and you're pretty much done with it. If you have latent syphilis or unknown duration, you're going to repeat that treatment every week for 3 weeks, so 3 courses of the penicillin. Alternatives are generally frowned upon, not necessarily because they don't work, but because we don't have a lot of evidence to say that they work. We haven't really studied things outside of penicillin. So if you have a really bad allergy, doxy is probably a good option as a second line, and that's the preferred option for Lyme disease, which is another spirochete. So that makes a ton of sense. But again, we just don't have the evidence to support that doxy is actually effective. But again, in a penallergic patient, if you have advanced syphilis, they actually recommend desensitizing you. So you do go through a desensitization protocol. And I think I mentioned that during the other lecture. Did I talk about desensitization a little bit? Basically do small doses and ramp them up until the patient's no longer sensitive to the antibiotics. Fairly effective. You can do it pretty quickly, and that would give them the option to use penicillin at that point. Neurosyphilis is super rare, but it does happen. All right. Moving on, sepsis and bacteremia. So I don't have much to talk about on sepsis that I haven't talked about already. Really, you're looking at critically ill patients. You're looking at an infectious source and a bunch of criteria they have to meet systemic inflammatory shock. So they usually have a bacteremia, but not necessarily. You can be septic with a local infection too, just due to the inflammatory response of the severity of the infection. So you can have a community-acquired pneumonia and be septic without a bacteremia. For septic patients, unless, again, like I said with the CAP example, if you have somebody who's septic, you don't necessarily need broad spectrum. If you can really nail down the source of the infection and the site of the infection, you might not need it. Or if they're uroseptic, you might be able to get by with just like a gram-negative coverage because it's probably not gram-positive. But for the majority of patients who come in septic, you can't really do that, and you're probably just going to go ahead and throw the kitchen sink at them. So Vanco plus something broad spectrum like Zosyn, carbapenem, or cefepime. I would say if you go with cefepime, consider metronidazole as well because that doesn't cover anaerobes. And if you think it might be a belly source, you want to make sure you've got that base covered too. Life-threatening, treat fast, treat aggressively. Studies are pretty consistent in showing the earlier you start antibiotics, the better mortality outcomes you have overall. So systemic inflammatory response syndrome is SIRS. So sepsis means you have SIRS criteria, at least 2 of them, plus a confirmed or suspected infection. Severe sepsis and septic shock is just where you have end organ damage. And then septic shock usually means you have hypotension that you aren't able to correct with fluid boluses and even vasopressor therapy. We'll talk about vasopressors in a few weeks, but that's just for your information. I'm not going to test you on SIRS criteria or anything like that. Just know that sepsis is broad spectrum, and it can really come from anywhere. So that's why I'm glossing over it. It is really important, but know that it's kind of an advanced state of illness in any of these conditions we've talked about. All right, other random stuff. Tuberculosis, don't worry about this at all. I'm not going to test you on tuberculosis, but just for completeness sake, tuberculosis is just a whole different beast. You can see all the drugs are odd. We haven't talked about any of these other than briefly mentioning rifampin. Excuse me. These are all taken for 2 months, and then the isoniazid and rifampin are taken for an additional 4 months after that. There's some other options out there. There's a ton of different ways you can treat tuberculosis. There's resistance and different parts of the world that recommend using other things. And again, I don't really care. Like fluoroquinolones are going to be an alternative you see used a lot. So like Levaquin is a common alternate for these. So we do use some of the more mainstream drugs, but for the most part, we start with these. And it's a fairly effective regimen. It's usually relatively inexpensive. One thing is that tuberculosis is a little interesting that usually it's recommended to use direct observational therapy, meaning that people come and get their tuberculosis meds and actually take them in front of you. It's kind of like a methadone clinic, if you guys are familiar with that. Like that's what it's like to be a TB patient. So that's the preferred choice just because it is taken so seriously. And then again, back to compliance, right? You want to make sure people are adherent with their medication regimen. So whether they can do that at home or have somebody sign off on it, I don't know how that all works, but it is recommended to be used DOT when you're treating tuberculosis. Anyway, I don't care you know about that. Lyme disease, I do care you know about. Super common in Minnesota. See it all the time throughout the summer. So tick-borne illness, I don't care you know anything about the way ticks mate or anything like that. I think you guys, has anybody not heard about this at some point in their career? Probably. So Lyme disease, early disease is the hallmark erythema migrans, which is this target-like symbol. People call it the bullseye, but if you're from Minnesota, you call it the target symbol, right? It's a deer tick that's going to cause it. The wood ticks don't transmit Lyme disease. So deer ticks are a little bit smaller, so there's a difference in the ticks. It is a spirochete like syphilis, kind of like syphilis, I should say. Doxycycline is our preferred choice. We're going to use 100 milligrams BID for 10 to 21 days. Amoxicillin and cefuroxime are appropriate alternatives. immunologic diagnosis is really complicated, especially when you get down the pathway of like advanced Lyme disease. But basically, not everyone's going to have an erythema migrans. So it's always a question of what type of symptoms you're looking at. Did they have tick exposure? I think people in this part of the country are probably more likely to think Lyme, especially in certain parts of the year, than maybe people in other parts of the country, unfortunately. So I think it does go undiagnosed in areas there. It's not in the person's forefront of the brain. Whereas if you practice EM in Minnesota or urgent care, you're always probably thinking Lyme on your differential when you have somebody who's relatively healthy come in with a odd kind of infectious looking presentation. All right, so advanced disease of Lyme, it's kind of like syphilis, like I said. So you have neurologic and cardiac related complications. Neurologic, you can have isolated facial paralysis, meningitis, radiculopathy, encephalitis. Cardiovascular, looking at arrhythmia even from cardiovascular damage to the heart tissue. AV block, different types of EKG abnormalities. Arthritis is kind of the more common second stage presentation. So if you have a erythema migrans or you got bit by a tick and you didn't notice anything, that's kind of what you would maybe present with after a certain amount of time if you didn't get treated. Usually for less serious, like not encephalitis or meningitis or AV block leading to an arrhythmia or something like that, we would treat PO and usually just extend the course of doxy a little bit. So do like almost a whole month of doxy versus a week or two. More serious, we don't usually use doxy IV, even though it does come IV. We could do that. We use ceftriaxone IV. Again, why? I don't know. That's what's studied. So they switched to ceftriaxone. Ceftriaxone also gets into the central nervous system really well. Remember, it's our meningitis drug. So if you do have neurologic complications, it's a great option to cover Lyme or cover the Borrelia burgdorferi, which is the bacteria. Ehrlichiosis and other tick-borne illnesses should always be on the differential too. That they might not show up exactly on the immunologic profile, but cause similar side effects. And I threw this chronic thing on here. Have anybody heard of chronic Lyme? I think it's a kind of a thing now. Chronic Lyme is a really controversial topic, and most of the mainstream infectious disease people don't believe in chronic Lyme, at least from a point that they think it's a chronic infection. So that's the big debate, if you want to call it that, is there's groups of people that believe that the spirochete itself can go latent in your tissue and kind of rebound. And so what you have sometimes see, and I've seen patients come into the hospital, very few doctors actually prescribe these things, but there are some that do it, and they give people these really odd continual regimens of antibiotics. So I saw this one lady who was getting a weird cocktail. She was getting Levaquin and ceftriaxone IV at home, and she'd get it for a week, and then during 1 month and the next month she'd get another cocktail and then she'd alternate back. It's a lot of antibiotic exposure over a long period of time, and basically it just is chronic and there's no end in sight. And I don't think there's any evidence to say it helps these people. So I'm not saying it doesn't exist. I'm not saying that Lyme disease doesn't have permanent complications, so I think it certainly can if you don't treat it. But I don't know if antibiotics are necessarily the cure for it, or if long-term antibiotic therapy is a smart choice for people. So anyway, that's all I'll say about it. I don't know a ton about it, but it is kind of an interesting thing. And certainly these spirochetes are just a different organism in general than what we're used to treating. So that's it. All of infectious disease crammed into an hour and 45 minutes.
Got it all. Got it.